Opioid prescribing and suicide risk in the United States. Part 2. It's printed in the American Journal of Psychiatry. Published online April 11, 2023. Results. Trends in opioid prescribing. Each of the 5 opioid prescribing measures declined during the 2009 to 2017 period. Regional opioid prescriptions per 100 persons declined from 70.19 to 61.63, and percentage of at least one opioid prescription from 26.4 to 20.27 percentage. Filling high-dose prescriptions from 2.01 to 1.60 percentage. Filing long-term prescriptions from 1.24 to 0.96. And percentage filling prescriptions from 3 or more prescribers from 3.18 to 2.26. Suicide deaths. Between 2009 and 2017, the regional rate of total suicide deaths increased from 13.8 to 16.36 per 100,000 persons. Change in total regional suicide deaths was positively associated with change in all 5 opioid prescribing measures. If there had been no decrease between 2009 and 2017 in opioid prescriptions per capita, we estimate that there would have been 3% more suicide deaths in 2017. In addition, there would have been an estimated 8.2%, 1.5%, 0.5%, and 4.8% more suicide deaths in 2017, respectively, had there been no decrease in the percentage with at least one opioid prescription. High-dose prescriptions, long-term prescriptions, and 3 or more opioid prescribers. For opioid prescriptions per capita, the association with change in suicide deaths was significantly stronger in the West than in the East or the Midwest. For percentage of at least one opioid prescription and with 3 or more opioid prescribers, the associations were stronger in the West than elsewhere, and stronger in the South than in the Midwest or the East. For males and females, change in regional suicide deaths was also positively associated with change in each opioid prescribing measure. For the 2 youngest and the oldest age groups, however, change in regional suicide deaths was not significantly related to change in any of the prescribing measures. Among individuals in the 45 to 64-year-old age group, change in regional suicide deaths was positively associated with the undetermined deaths involving opioids. The annual regional rate of opioid overdose deaths of undetermined intent was little changed, from 0.73 in 2009 to 0.93 per 100,000. Change in total undetermined deaths involving opioids and significantly and positively associated with change in all of the prescribing measures except percentage with at least one prescription. Among females, changes in undetermined death involving opioids was positively correlated with change in opioid prescriptions per capita and percentage with long-term opioid prescriptions. For individuals aged 65 and older, change in undetermined deaths involving opioids was also positively associated with change in opioid prescription per capita with at least one percentage with at least one opioid prescription and percentage of with 3 or more opioid prescribers. Discussion. In the United States, geographic regions with the greatest declines in people filling opioid prescriptions also tended to have the greatest decline in total suicide deaths, including suicide overdoses involving opioids. These associations were most robust across all 5 measures of opioid prescribing and tended to be strongest in the western United States. providing population-level evidence linking opioid prescribing to suicide risk. We estimate that, other things being equal, had the national decline in per capita opioid prescriptions between 2009 and 2017 not occurred, there would have been 3% more suicide deaths overall in the United States in 2017 and 10.5% more suicide deaths. These estimates may reflect not only the high lethality of opioid overdose events, but also the exceptionally high risk of suicide by all methods among individuals with opioid use disorder. For 4 of 5 prescribing measures, decreasing regional opioid prescriptions were also related to declining total opioid-related overdose deaths of undetermined intent. Conversely, for 3 opioid prescription measures, regional declines in opioid prescribing were associated with significant increases in unintentional opioid-related deaths in the 2 youngest age groups. Regional associations connecting decreasing opioid prescriptions to declining suicide deaths are consistent with clinical research suggesting that opioid prescriptions can contribute to suicide risk in susceptible individuals. In a post-mortem study, people who had died of intentional overdoses were more likely than those who died of unintentional drug overdoses to have had prescriptions for opioids prior to death. In addition to the direct risks related to intentional overdoses involving opioids, longer duration of opioid prescriptions have been related to increased risk of new onset and recurrent depression, which may mediate increased suicide risk. Although the present population-level research cannot establish that opioid prescriptions cause death by suicide, the results are consistent with the view that opioid prescription policies and practices should give careful attention to possible connections between prescription opioids and suicide risk. While the results support consideration of local opioid prescribing practices in suicide prevention initiatives, this ecological level analysis do not shed light on the clinical pathways connecting local opioid prescribing to individual opioid overdose suicide deaths. In order to assess the effects of opioid prescriptions on an individual's risk of suicide, it's necessary to analyze prescription records that are linked to death records at the individual level. In line with our population-level results, the patient-level case control study with veterans with chronic non-cancer pain conditions reported that higher dose opioid prescriptions were associated with increased suicide risk. Interestingly, the strength of the association of opioid dosage with overall suicide mortality was similar to the strengths with suicide overdose deaths. In relating the results of this panel analysis, it's important to consider the potential for confounding factors to bias the correlation coefficients. For example, overdose deaths have been related to several population-level variables, including poverty, unemployment, low educational attainment, income inequality, and lower social capital, while similar regional factors have been correlated with rates of opioid prescribing. However, a key advantage of fixed effects models is that they can control for all variables that vary across regions but are constant over time. The present findings contrast with the weak relationship of local opioid prescribing and prescription opioid suicide overdose deaths previously reported from an analysis of 89 local health areas in British Columbia. Because the Canadian study and the present analysis differ in analytic design, power, location, and study period, it's not possible to determine the primary reason for the divergent findings. For 4 of the 5 prescribing measures, there was significant positive association of opioid prescribing with unintentional overdose deaths involving opioids, and because suicide overdose deaths are particularly prone to be misclassified as undetermined deaths, It's possible that the observed correlation between opioid prescribing and undetermined opioid-related overdose deaths, which was most apparent among older adults, is particularly attributable to misclassed suicide deaths. This hypothesis is supported by research with electronic health records indicating similarities between suicide and undetermined overdose deaths in their pattern of mental health diagnosis, toxicological data, and recent stressors. In a sample of inpatients in treatment for opioid use disorder, most 58.5% of the inpatients reported at least some desire to die before their most recent overdose, and over one-third, 35.8%, expressed a strong desire to die. For the two youngest age groups, significant negative associations were identified between three regional opioid prescribing measures and unintentional opioid-related overdose deaths. In regions with falling rates of opioid prescriptions, it's possible that some individuals, including younger adults with opioid dependence, turn to heroin and other illicitly obtained or manufactured opioids that pose greater risks of unintentional overdose. For example, there were negative associations between having three or more opioid prescribers and unintentional opioid deaths in the younger age groups. Opioid prescriptions, doctor shopping, which peaks around the age 30, is associated with opioid dependence and low rates of treatment seeking. Facing local declines in the availability of prescription opioids via multiple opioid prescribers or other sources, some individuals may initiate use of non-prescription illicit opioids. The present analysis has several limitations. First is an observational ecological study. This analysis cannot establish cause and effect because of potential confounding by time-varying factors within each commuting zone. We cannot infer that the local changes in opioid prescribing patterns are divergent changes in the various mortality outcomes. Second, as stated above, it's difficult to classify overdose events occurring according to intent, and this may be particularly true for fatal events. Third, the analysis only captured changes in prescription opioids and lacked a means of measuring illicitly obtained opioids that are directly involved in a large proportion of overdose deaths. Fourth, due to incomplete population coverage of the IQVIA prescription data, there is uncertainty associated with the opioid prescription measurement. Finally, because the opioid crisis has evolved from being closely tied to prescribed opioids to being related to illicit heroin and fentanyl, and because the COVID-19 pandemic may have had population-level effects on suicide risk, results from the 2009 to 2017 period may not directly apply to contemporary conditions. Because opioids pose a greater risk than any other drug class that an intentional overdose will prove to be lethal, it is not surprising that regional decline in opioid prescribing were found to ameliorate local trends in suicide deaths. These findings reinforce the importance of safe opioid prescribing practices and proper disposal of unused opioids. In managing patients with pain, physicians should evaluate whether adequate relief can be achieved with non-pharmacological interventions. While some patients with pain need and benefit from opioids without risk, those for whom opioids are prescribed should be evaluated and, if necessary, treated for co-occurring mental health disorders that might otherwise increase their risk of suicide. Finally, despite the epidemiological linkage between regional decreases in opioid prescribing and lower suicide risk, Some patients who are physically dependent on opioids develop serious withdrawal symptoms that may include suicide when the opioid medications are suddenly discontinued or the dosage is quickly decreased. Footnote: the opinions expressed in this article are the author's own and do not reflect the views of NIH, the Department of Health and Human Services, or the U.S. government. It's printed in the American Journal of Psychiatry.